welcome to the Lung Cancer Living Room, coming to you live from Colorado. We're really happy to be out here in Cherry Creek tonight. Thank you for having us. Welcome to everyone signing in online. For those of you who don't know me, my name is Danielle Hicks, and I'm from the Bonnie J. Dario Lung Cancer Foundation. My role at the foundation is overseeing all of the patient programs and services, education that we provide. So with that, I'm going to turn it over to the team, and I'm going to start with Dr. Camage, but then I'm going to ask everybody to kind of talk a little bit about the very first question. And we don't have to stay on script at all, so if you guys, if something
We're not going to, don't worry about it.
I totally know we're not going to, trust me. I know that's what's going to happen. But because the topic tonight is the importance of a multidisciplinary team, I think it's important for those who may not know, those who are in the room, online, or who will come back and watch later, what is a multidisciplinary team and why is it important? Who are the players? What do they do? And why is it important that every patient have one?
So it's a bit of a buzz phrase, and you hear people talk about multidisciplinary team, but it is what it says. It's one individual can't know everything, and we all have our biases and our prejudices, and so by getting together people who have different views on the same problem, you can help each other out, and so the team it's very large, and sometimes there's the patient-facing side, which people might experience. So that's the treating aspect, which will be surgical oncology and radiation oncology and medical oncology, and to some extent pulmonology. But then behind the scenes, we have people like Dara, who are pathologists. We have radiologists who look at the scans, and then we have all those other supportive services like social workers and dietitians and pharmacists. And what you don't see, your ears, if you're a patient, your ears should be burning all the time, because we do talk about you behind your back. And it's not just, wasn't so-and-so terrible today, but it's more kind of like, well, what do you think about this? And what's the latest breakthrough in this? And what's the best way to work together? So that's what a multidisciplinary team is. One thing it's not, and I was chatting to Colin about this, it's not a corporation. It's not a way of removing responsibility. You still have a doctor, and your primary doctor is the one responsible for you. But it's about putting people's heads together to get the best for one person who that doctor is responsible for.
How does a patient know whether or not they have a multidisciplinary team? Do they?
Well, if they have to ask, they may not have a multidisciplinary team. So again, it kind of depends on the vagaries of infrastructure. So in big programs, everyone's working in the same center and is in the same physical space, and so you can have this interaction all the time. Sometimes you can jerry-rig that. If you happen to be a standalone oncologist, you may still have a great relationship with a surgeon and a radiation oncologist, but they may be in separate practices, and so physically you're sending people around. You can email and you can phone, but a true multidisciplinary team is often where literally you can all be in the same room at the same time, sometimes even with the patient, so you can, throw things around.
So this is where I'm going to start to take it off script for just a second. So I'm Janet.
Hello, Janet.
And you're my treating physician.
Okay.
This is where this whole the idea of shared decision making and what that conversation, what does good look like, that conversation between physician and patient, right? How do I know that you and Dr. Rusthoven have had a conversation about my case? Are you telling me? Does that always happen? Why is it important that it does happen?
Well, Chad can talk about this, but I have a clinic on a Tuesday and a Wednesday, and pretty much I phone Chad pretty much every week. You're probably expecting the phone call, and more often than not, he will see that patient same day. It's not unusual for him to literally come up the stairs, and he's physically there in the room with me. And there's no substitute for that. We're discussing things in front of the patient, and the patient is part of that dialogue.
So go ahead, Janet. Yeah.
So, and it's different in different institutions. So I was treated originally in Seattle, and the multidisciplinary team there was trying to evaluate whether or not a particular nodule was something that they needed to do something about or not. And my pulmonologist walked in the room and said, I talked to the tumor board last night, and told me everything that they'd discussed. So.
And at that point, from a patient perspective, did you know what a tumor board was?
Well, by that point I did. The first time you did what? So, but by the way, you mentioned, how would I know if my treating physician does. He knows I'm going to ask him. So can I presume that if the facility I'm going to is a comprehensive cancer center, that they have multidisciplinary teams?
Yes, I think so. I mean, Chan, do you want to? I mean, radiation oncologists, I think, do you think you're always in a multidisciplinary team?
Well, yeah, we're kind of a consultant. We're downstream typically of the medical oncologists, which are already a specialist. So by the time that, in most cases, that a patient gets to us, they've already been thought about by several people who have expertise in cancer. So in some ways, that's probably true, though I think that at a university, there's a lot more emphasis on kind of getting together face to face and having things like tumor board and having offices close by where we're actually all under the same roof. That's not to say you couldn't have that in other places, and there are other examples where that can be the case. But I think that's one thing that you will often get at a university.
So
what I was
before we-
going to say
Go
about
ahead.
what I was going to say about this is that for a lot of the components of multidisciplinary care, they happen one way or the other, right? If you get a biopsy, a pathologist is going to look at it. If you get a CT scan, a radiologist is going to read it. If you get a pulmonary function test, it's going to be evaluated by a pulmonologist. The major distinction is that at some point in time, we all come together and we can not just bounce ideas off of each other, but we can take into account a whole picture that's otherwise very hard to take into account if you're just looking at your one little slice of it, right? So, for example, in tumor board, we might have a case that just seems, oh, this is so obvious what should happen, and the social worker will pipe up and say, well, but this patient lives 6 hours away and doesn't have great transportation. Aha, that changes things, right? So what do we do with that new piece of information? And I think a lot of multidisciplinary care is taking all of these fragmented pieces of information and having people just focus on all of it come together, even if it's only for a couple of minutes, right? Just bring all of it together to look at it at one place, one time, and get everybody's eyes at the same time looking at it. And it makes a really big difference. There are a lot of aha moments.
I agree. I think there's basically what you're saying is it's sort of de-siloing, right? Asking everybody to come out from the information they received. The radiologist, looks at the scans and that's what they have. But until the conversation happens, right, with how are we going to, biopsy this and what does that look like and molecular testing, so on and so forth. So at University of Colorado and academic centers and large community centers around the country, this is what you can expect. But it is also pointing back to why it's important that your physicians are specializing in your disease. Because in a very small community center in a rural area where a radiation oncologist is treating whatever walks in the door, right? Regardless of what kind of cancer this person may have, they might not have the benefit of the expertise that Dr. Rusthoven has and what he's talking about when it comes to radiation care. 80% of patients are seen in the community setting, right? So 20% of the patients have the benefit of access to teams like this. So it's important that, again, I'm pointing back to meetings like this, to be able to reach patients who don't have that access so that we can help them to engage in this conversation with their physicians. And with that,
Can
yes, please.
Since you're talking radiation oncology, could you explain to patients why sometimes they can have stereotactic radiation and in other times it's not possible? Because that comes up a lot in the patient groups.
Sure. So first, just for people who aren't familiar with that term, it's probably good to define some of the terms in the question. So stereotactic radiation is kind of a buzz term. It's one of the kind of the newer technologies that we've developed in the field of radiation oncology, not just at the University of Colorado, but the field has developed this technology and brought it to the clinic within the last decade and a half. It's become more mainstream. And so stereotactic, actually, what it's usually referring to is very focused treatment to a higher dose that's delivered in typically maybe 1 to as many as 5 treatments. And then you can blur those definitions a little bit, and sometimes we'll still refer to things as stereotactic radiation up to 10 treatments. So it's usually a pretty short course with, again, focused high-dose treatment. And there's a number of indications for treating tumors that way, but if you just wanted to kind of do it in broad strokes, what you could say is, if you're going to deliver a focused high-dose treatment, you have to have a very well-defined target, and it has to be not too large, because if you're delivering a high dose of radiation, if the area is too large, you start to worry about causing side effects or affecting other normal tissues and organs that the tumor may be close to. So common scenarios where we use stereotactic radiation, one of the scenarios is actually early stage lung cancers. So if someone has a stage 1 lung cancer, typically that means they have a very well circumscribed, well-defined target that we can treat without any lymph node involvement, and they don't have cancer in other areas of their body. So we're focusing on a well-defined area, and so we deliver a high dose of radiation in a very precise fashion to that spot with the hopes of eradicating and getting rid of the tumor for the rest of the patient's life.
And with that, I want to go to Dr. Eisner, whose job it is to ensure that your treating physician knows exactly what your cancer looks like and how to treat it. So, Dr. Eisner, can you tell us a little bit about what you do?
Sure. So I feel like I need to talk both about pathology in its traditional kind of classic sense, as well as molecular pathology, which is kind of the new frontier of pathology. So pathology in the classic sense goes back to the days of Anton von Leeuwenhoek and his microscope. And really, microscopy has gotten a lot more sophisticated in terms of the optics, but the idea remains the same, which is we want to look at things under the microscope to try to characterize disease. And what I do know, because I've heard this from many people, is that there's this big black box. I had a biopsy, and I'm waiting for pathology, and it's going to come back, right? And what happened between that biopsy and the report is something, and I'm not entirely sure what that was. So I'm going to try to explain it to you, usually a little better done with pictures, but whether it's a biopsy or an FNA or a full resection
what's an
of some
FNA?
sort. Sorry, FNA is a fine needle aspirate, which is similar to a biopsy, but is a little bit less invasive in the sense that a very small needle is used to pull back and basically by negative pressure suck cells out of a lesion. And so regardless of the methodology you use to get tissue from a lesion, a pathologist's job is to look at that tissue under a microscope to characterize, is it normal or abnormal? If it's abnormal, what is the nature of the abnormality? And while a lot of what I do is about describing the nature of specific cancers, see, waiting really did help.
It did.
There's the whole entire spectrum of everything that could potentially impact a tissue. So cancer is one of the things we think about, but we also think about infection, inflammatory diseases, lots of different things that can lead to an aberrant imaging or clinical symptoms that leads to a biopsy or an FNA. Now, you go, okay, that just tells me that you look at a microscope. You just said the same thing. How do you do that? Well, really what we do, and I'm going to talk more about a biopsy here, is we take that piece of tissue and we put it through some very fancy machinery where the goal of it is to essentially desiccate it into something that's much harder than the tissue you might just be able to touch and feel. So if you've ever been to see exhibits that were popularized 15, 20 years ago, Bodies.
Body Works?
Body Works, Bodies in Motion.
I refuse to go and look at those. Like, gross me out.
It was amazing.
We know where you were during your anatomy class.
Yeah, it's squeamish. Yeah.
So if you've ever seen the Bodies exhibits, you know that that's a sort of plastinization. And we do something very similar with tissue. We take the tissue and we desiccate it, and we use a lot of chemicals. And at the end, when all of that is said and done, a piece of tissue, which is normally squishy and very deformable, and if I did this to it, I would make it hard to recognize, gets made into something quite firm. And then we embed that in a piece of wax, and we essentially slice that piece of tissue on what amounts to a super mini deli slicer. And we cut tissue at 4 or 5 microns thick. So we then stain that tissue and we can look at it under a microscope. And it's through the training of spending a lot of time with my eyeballs in a microscope that I can say that cell's normal, that cell's not, right? And we basically are experts at pattern recognition. We look at a whole cast of patterns, and diseases tend to cast themselves in patterns. And cancer is one of the different types of patterns we can see under a microscope. Now, you might have heard about immunostains, right? The tumor was positive for this and negative for that, and it turns into this crazy alphabet soup. It was positive for CK7, TTF1, and negative for, right? This is highly technical stuff about how cells differentiate, and the fact that some cells, when they differentiate, turn on some things and turn off other things in terms of their genes. In short, what we can do is we can take those super thin sliced sections, we can put special antibodies on top of them, and then we look for where the color indicated that antibody was sticking. So for example, TTF1, very common marker in lung cancer, I look for, is there color in the nucleus of these tumor cells, right? It's important because if there's color all over the tumor, the tumor cells, is not the same as it being in the nucleus of the tumor cells. So for every stain, I kind of have a mental Rolodex. This stain's supposed to look like this in these cells. This other stain's supposed to look like this in these other cells. If it looks like this in this cell, then it doesn't belong there, right? So it's this pattern of what belongs and what doesn't belong that allows us to characterize tissues as normal or abnormal using those stains. And it also allows us to characterize, this is a tumor that came from a lung origin versus this other tumor came from a colorectal origin versus this other tumor is a lymphoma, right? And that's how we're able to do those things both with how the tumor cells look in the microscope and with those immunostains.
So moving beyond that, once we determine, or you determine, what you're looking at, that this is, in this instance, a lung cancer, what next? What are you looking for after that?
Well, I think one of the things that's sometimes not apparent to people is while some pathologists sort of get cases delivered to them and there's a stack of cases and you're looking at the slides and you're reporting what you see on the slides, that's really just a very narrow slice of pathology, right? And if I work where I only report out what I see in the slides, I'm sort of missing the opportunity to be what I was joking with a friend earlier today is a diagnostic integratician, right? A lot of my job is diagnostic integration. And really for me, so much of the reward of the job isn't that, gee, I know what this is because I learned how to recognize it. It's, I looked at the patient's record and this helps make the whole thing make sense, right? I want to help make the picture make sense. And so depending on at what point in the process I'm seeing a pathologic sample, if it's a diagnostic biopsy, particularly in lung cancer, my number one priority is how do I get to a diagnosis of lung cancer while maximizing the material for the molecular testing I know we're going to need, right? If it's a staging case, if it's a resection for early stage lung cancer, my priority is how do I make sure that the physician or physician's assistant who was at the bench looking at the specimen took all of the pieces properly so I can arrive at the right final pathology stage, right? Yet again, in a different situation, which is a very active area of research for us, for patients who are on targeted therapy and experience a progression on therapy, oftentimes we want to biopsy those lesions so we can try to understand what is driving that progression, right? And that's yet a different mindset for me. What does this look like now? Does it look mostly like tumor response? Does it look mostly like necrosis? What does this look like and how does that integrate into what I know about this lesion and this patient's past care. So that's kind of the pathology piece. The whole premise of targeted therapy evolved from designing a drug for a disease called chronic myelogenous leukemia, CML, which when it hit its aggressive phase was a very bad actor. And this is now truly and honestly a chronic disease. We monitor it with a blood test to check and see how people are doing. And I really foresee that that is where we can and should be aiming.
I think, just a comment on that too. Clearly I have a lot of comments based on comments tonight, but that's a really, really great example, especially when you're looking at the blood diagnostics that we barely got to touch on tonight, and sort of where they're going and how much more quickly they're getting there than I thought they would when it first started. So all very, very positive. Janet, do you have any final thoughts on how you feel about this?
Just to build on what you said about Gleevec, there was a discussion online just recently that the patients who are now on that targeted therapy, which just got approved in 2001, actually have a life expectancy that's approaching normal. I would love to see us get there. That said, in lung cancer, it's a little different to be chronically terminal, when we still can have our next scan and find out things have changed. When we have, some of us are living long enough on targeted therapies that we're starting to get late effects of radiation that no one had seen before. So I'm very hopeful in the direction we're moving, but I'll feel more hopeful when we have it for all types of lung cancer and not just the few of us who have targeted therapies.